So thank you for joining me this afternoon to talk about patient engagement as strategy and what would happen if patients ran our hospital. So this may be the first presentation I do from behind the podium because there's nothing to clip the mic to. But I'm going to step out for just a moment. You might be wondering about the attire, not my usual uniform, but I think important to, thank you, that's actually nice, important to our topic today. At the classic hospital gown, we walk by it every day and probably don't think much about it, right? And when we think about patient engagement, the classic hospital gown is, I think, a good place to start. Designed in the 1920s, hasn't changed much since then. Big surprise that it hasn't changed much since then. 60% of our patients tell us they dislike or very much dislike wearing this. And I don't know what's wrong with the other 40% because I have to tell you, I am not really excited about standing here in front of you in this. It seemed like a good idea until I got into the bathroom and changed. But I think it's emblematic of our topic today. I once saw a presentation from a very senior physician who talked about being treated for cancer. And I'll never forget what he said about his first hospitalization and what it was like to put on the hospital gown. The sense of vulnerability that he felt, the loss of control, the loss of dignity and status, and a bit of helplessness that he felt when he put on the gown. And it changed him, and it changed the way he interacted with his patients. It changed the way he saw his patients, and I think it changed his practice pretty significantly. So I think it's fair to say that if patients ran our hospital, we'd probably be saying goodbye to the hospital gown. So patient and family-centered care, this isn't new. I've had people, when they've talked about this topic, this is new, this is not new. Plaintree was founded in 1973, and they're an organization that has been dedicated since that time to improving patient and family engagement in healthcare organizations. So we're not talking about something new. But we're talking about it today in a little bit of a different way. And I heard this description about how hospitals have evolved in terms of how they describe their care models. And it was described this way. So we like to draw diagrams of what it is our care model is, so you can all think about diagrams you've seen hospitals draw over the years. And so in the 80s, we would draw these, they would draw these diagrams, and sometimes the patient was there, but sometimes the patient wasn't in the diagram. And then in the 90s and the early 2000s, we got smarter about our diagrams, and we started putting the patient in the middle, right? Because everything was about the patient, and the patient was in the middle. And that's good. That was good progress, but what we're talking about today is actually moving the patient from the middle out to the circle or the triangle or whatever the shape is to the care team. And engaging with patients in a different way to design the way we deliver care and to be a part of their treatment planning and treatment decision making. So let's start with how do patients define patient and family-centered care, which is crucial to how patients define this. So these are some definitions from patients, and right away you see things that may or may not be consistent with how we design things. Patients are looking for an emotional connection. Think about our care processes and whether they enable us to be making an emotional connection where we're not just dealing with the disease in front of us, but actually considering the psychological impact of the treatment. Patients tell us it's the total package. From the second I step out of my car in the deck to the second I am back home, it's the total package. So it's everything in between that happens. and that families are very prominently involved in these definitions. So over the years, one of the things that you do as an administrator is you come in to handle the complaints. And over the years, I've been called in, and this hasn't happened since I've been at UTMB, to handle a complaint where I've been told, well, the problem is really the family, and the family, not my patient. So that kind of thinking, our patients tell us when they define what is patient engagement and what is patient and family-centered care, the family is part of that definition. And I think you're going to see over the course of this talk that they actually can be quite helpful in being successful in executing this as a strategy. So in addition to our patient definitions, the Institute of Medicine helped us out with some definitions, and they really, with the Crossing the Quality Chasm, made patient-centeredness a key component to quality. And so they have their own definition, which I think is important to reflect on, as well as a definition from Plaintree. So in these definitions, what stands out for me are the words partnership and participating in their own care and consideration of individual preferences and decisions based on the patient's values. Those were the things that sort of stuck out to me in these definitions. And as I reflected on this and I reflected on those words, I started thinking about my dad. And my dad, some of you know, had heart failure. And after his cardiac disease advanced to heart failure, like a good daughter, I found the best heart failure specialist in St. Louis for him to go to. I got him in. It wasn't easy, but I got him in. And I was very proud of myself. And so he came back from that first appointment and said, "Deb, where did you find this guy?" He's the pits. And I was pretty deflated because I thought, okay, I took a lot to get him in, and also I was worried because I knew this guy was the best. He was the best in St. Louis. And I knew that he had the most current treatment protocols and that my dad would get the best treatment plan. And my dad said, you know what, he didn't listen to me. He just spit out what he told me to do, and I'm not going to do that. Now, full disclosure, my dad is what we call non-compliant, right? He always was non-compliant. Poorly managed diabetes, poor diet, didn't exercise, took his medicines on his terms. So I'm sure none of you have either seen patients, have family members, or maybe I'm talking about you right now. So he was non-compliant. And so I went on for years battling with him to try and get him to follow this treatment plan. And then as I got into this literature, as I started to evolve in terms of my thinking about what healthcare should be, it occurred to me the system wasn't working for my dad. There was no partnership. There was no treatment plan based on what he wanted out of his life. It was, this is the best treatment plan to deliver the best outcome according to the research, but didn't encompass any of what my dad wanted. So it occurred to me that maybe he wasn't the problem, that the system and the way the system was approaching him might be part of the problem. And it certainly didn't follow the definitions of patient and family-centered care. So I think once we get rooted in the definitions, it's important to debunk some of the mythology that has evolved over the years with this concept. So the first is, nice idea, but this is going to cost us too much money. So let's go back to my lovely attire for this afternoon, the hospital gown. We can start here. This is not cost effective. Anybody know why? 2 gowns, right? You got to cover the rear view of this thing. And even then, I will not be turning around, even though I have the second gown, because I'm aware of the rear view. So this is not cost effective, right? Additionally, care providers say this slows them down, it gets in the way of what they're doing. This isn't cost effective. Further, there are studies that show patient and family-centered care can be more cost effective We actually talk to patients and engage them in designing our systems. They design things that are less expensive. So let me give you an example. Plaintree did a study of 2 hospital units in an organization that was adopting their patient and family-centered model. Now these 2 units were essentially the same payer mix, same case mix, same staffing ratio, in the same healthcare system, so same policies, same leadership. And in the Plaintree Hospital, over 5 years, on the Plaintree unit, over 5 years, they showed lower cost, shorter length of stay. No kidding, patients don't like being in the hospital. And so shorter length of stay, lower cost. They were able to have fewer hospital readmissions and higher patient satisfaction. So in effect, this isn't going to cost us more necessarily. It's about asking patients and engaging them in the design and letting them determine where value is and being a part of that discussion. So let's go to myth number 2. This is nice, and actually I had my employee breakfast this morning and this was a theme. We are too busy. And we're too busy with things that, like, documenting an epic or doing paperwork or going to meetings. We're too busy for this. So I have to say, so this as a framework and as a strategy is not something else to layer on top. It's about 2 things. One, connecting us back to why we're all in healthcare, because I am guessing what gets you up in the morning is not documenting an epic. Sorry, Tim. or Mark. I know it's what gets you up. Tim, we'll talk about that later. But for the rest of us, it's stuff like that. It's about connecting with patients. It's about doing something for the good of our patients that got us into healthcare for the most part, right? So it's about connecting back with that. And in terms of being too time-consuming, often we find that we're doing things that patients don't find any value in at all. So let me give you an example of what I mean by that. Very early in my career, I was the manager of a heart transplant program. And every year, we had this very stressful time where we updated the patient education binder. And by binder, let me tell you, we had this. Every patient got one of these. And we gave it to them when they came for their evaluation. And it was very important to the staff. But it was driving them a little crazy because it was very time consuming to try and keep updated. And I said, maybe we should think about how we're spending our time educating our patients. And they're like, no, this is all the stuff they need to know. And let me tell you, there was basic anatomy and physiology. There was every medicine they were going to be on post-transplant and every single side effect. It was overwhelming. So I said, well, let's just take a step back and let's do a focus group. And let's ask our patients what they think of this. And so they told us some important things. One, we didn't read it. We didn't read it. We read parts of it, but we didn't read the whole thing. That anatomy and physiology, we skipped that. So they told us that. They weren't reading it. We were spending hours and hours and hours creating this thing they weren't reading. What they also told us was very interesting. They told us what would be really helpful and what was helpful and what we figured out how to do on our own was connect with other patients who've been through this. And that was very instructive, and it helped us figure out, things like how to set up your meds in one of those Smithwicks. You know what I'm talking about, those little medicine things? So how to set up your meds every day and how to alarm yourself so you know it's time to take your meds. That kind of information was what they were looking for. And so we redesigned our education plan. We stopped doing the binder. It was hard. We let go of the binder. And we got other patients involved in the process. So our nurses actually spent less time doing education because we trained some volunteer patients to help and make those connections that our patients were asking for. So if you ask your patients, you may find, and in many cases you will find, that there's a lot of non-value added stuff from their perspective that are actually time savers. So let's go to myth number 3. This is really about the nurses, isn't it? Thank you for the couple, 3, 4 doctors in the room. Thank you for coming. And thank you for all the nurses for coming, but I hate to break it to you, it's not just about the nurses. You remember our patients definition, it's the total package. It's everyone. So we can't be effective at engaging patients and driving this as a strategy for the organization if we think, well, we're just going to leave this up to the nurses. Now, don't get me wrong. Our nurses do a fabulous job of smoothing bad process. Smoothing over bad communication, smoothing over bad process, great. Service recovery, great. But there's only so far you can get with that. It has to be the total package. Let me give you an example of what I mean by that. So let's go back to my dad. So he had lots of hospitalizations being a non-compliant heart failure patient, and I would always ask him questions about what his stays were like. And there was one hospitalization that stuck out. The one he said the hospital was good. We finally found a good hospital. And I said, okay, Dad, what made it good? It was how people talked to him, the doctors talked to him, how the nurses talked to him, how everyone talked to him. That they listened, they asked questions, they made sure he understood. But what sealed the deal was the lady who cleaned his room. Now this lady, she made sure my dad had his booties every day. And she explained to him, I don't want to make sure you're wearing them because your floor isn't clean. Because your floor is clean, I am keeping your floor clean. But I know you don't want to be here, and I know you want to get back home, and I don't want you to fall. And that made a tremendous difference. It made a tremendous difference because she understood him and attended to him in a way that was meaningful. So it takes us all. It's not just the nurses. The nurses can play a big part in it, but it's not just the nurses. So this is all nice and fluffy stuff here, you might be thinking. But Deb, our patients aren't really complaining. Patient satisfaction is up, right? So it is up. We're doing better on the inpatient side. We're about at the 80th percentile now. We've improved. On the outpatient side, we're about the 60th percentile. It's a new tool. We're learning it. So it's up a little bit. So we're improving. And generally, when you read our comments, our patients say we're pretty nice to them. So that's in the comments. But what is also in the comments is a lot of our processes just don't work for them. And that comes through loud and clear over and over again. The time we draw their labs, which is what time? 4. Now, I realize it's healthcare. How many of us are up at 4 every day? Okay, we can talk later. Okay, that's not normal. 4 o'clock. I'm so not a morning person. So 4 o'clock, that's not normal. People outside of healthcare generally don't get up at 4 o'clock in the morning, right? So that's not working for them. They're not getting their rest, which last time I checked, sleep is pretty important to healing and recovery. It's important to me. I know what I'm like without sleep, and I know what I'm like with sleep. It's much better with sleep. So they tell us that. They tell us the admission process doesn't work for them. They tell us the discharge process is working better, but our readmission rates tell us maybe not all that much better. Okay? So the other thing I would comment on is patients don't always complain, right? We know that, right? So they don't complain for a variety of reasons. They don't complain because they want us to like them. They don't complain because they don't want to be a bother. They don't complain because they're nervous. Complaining may get them retaliated or in some way less good care. So you have to be sensitive to that. So clearly, this is the right thing to do, right? This is part of what probably drove most of you to healthcare as opposed to something else. But I've been talking about patient and family-centered care as strategy. which is a little different and sounds a little businessy maybe. And so how do those two things relate? So let's start with value-based purchasing. How many of you know what value-based purchasing is? Okay, so value-based purchasing is the brainchild of our federal government and actually kind of clever. In 2005, CMS started collecting quality data, process measures, developing patient satisfaction measures, and outcome measures. They started collecting it. And then in 2010, they said, we have this great idea for you, healthcare. We are going to, instead of giving you $10, give you $9 and let you earn back that extra dollar based on how you perform in these areas, right? So if you do better, we may give you a little more. If you do worse, we're going to keep your dollar and give it to somebody else. And if you perform at the median, you get to earn back what we used to pay you. Sounds like a good deal. Makes a lot of sense and actually has been very successful. And so what are these measures? So clinical process of care measure. Did we give the right antibiotic at the right time, and did we stop it at the right time? Outcomes, mortality. Do we have higher than expected deaths in the hospital? And then patient experience, our HCAP scores, which everyone I think is familiar with. So these are the things that they look at and evaluate us by. And it's been successful. And what have hospitals and health systems done? They've improved. They've improved nationally. The bar keeps going up, and we keep trying to get better so we can earn back our dollar that they took from us. So it's been successful. So what do you think they're doing? They're expanding the program, right? It was successful, so let's do some more of this. So they're expanding it to things like 30-day readmission rates. But in this case, little catch, when you come back to the hospital within 30 days, they don't pay you, right? So you get nothing. So it's a little different flavor, but it's expanding, and the amount of money, that dollar is going up every year. So $1 will become $2, and it is going up every year. So when you think about this strategically and you think about the kinds of things they're measuring, I think our patients would tell us, if they ran our hospital, we could probably help you be more successful in that. You think about readmission rates. So people bounce back to the hospital because the treatment plans fail, right? We had a good plan, but the patient didn't follow it, and they bounce back. So more often than not, that's the story. I think about a situation with my grandmother. She had an admission for PEs. Now this is a lady who was years old, taking care of 2 adult daughters. She cooked and did their laundry in the basement. I mean, she's a pretty spry 86-year-old. She was completely independent. Goes into the hospital for PEs, is in the hospital for 9 days, stays in bed for 9 days, and is discharged and bounces back 2 days later. What do you think happened? Oh, by the way, has 9 children, has a great support system, is pretty compliant as a patient, does what she's told. What do you think happened? Didn't have pneumonia. She got deconditioned because you know what? She was a fall risk, so what did we do? Don't get out of bed. So that's a big assault for an 86-year-old on her physical capacity. She fell. She fell 2 days later. And she fell because we have this great treatment plan that failed to mention she's decompensated. Family, you now need to be supporting her. You need to help her in the bathroom. You need to help her shower. You need to help her, oh, they didn't realize. So you can see if we engaged our patients and their families in a different way, if we did functional assessment and looked at, oh, what was the picture of her before, and then what was the picture of her after, and what should we be telling the family that she needs in terms of support at home now, that could have gone better. So if patients ran our hospital, I think they would say they could help us be more successful in this arena. So the other thing Medicare has done to sort of change the dynamic for us and to make this more of an important strategy for healthcare organizations is they've started to be more transparent with all the quality data that they're collecting. So all of the data that we talked about that they pay us or don't pay us for is posted on a website for everyone to see. And initially, I have to say that when they posted it, it was kind of hard to understand, but they're getting better at explaining what it means. And so all of that information is out there. So what does that mean for us strategically? It means our reputation is on the line. And for UTMB, a big part of what we're doing strategically is growth. And a big part of growth is our reputation in the community. And so when you think about patient and family-centered care as a strategy, you can see how this connects back to our success in terms of growth. So we've been talking a lot about Medicare, but also the commercial insurers are looking at the Medicare program and taking note, and I think are moving in that direction to pay for quality. But the other thing that's happening is as healthcare costs have gone up, more of those costs are shifted to employees, right? And so what happens when I start having to pay more out of pocket? I get more choosy. So healthcare consumers, our patients, are comparing us. They're looking for data. We've got health grades, we've got Rate Your MD. If you haven't looked, if you're a physician and you haven't Googled yourself, you should, and see what your patients are saying about you. So the perception of patient experience is important from an HCAHPS Medicare perspective, but it's also important for in terms of our strategic growth and our reputation in the community. So this may feel to some in the room like fluffy stuff, I use that word. But over the last several years, there's been a fair amount of evidence that says this isn't fluffy and this is directly related to how we perform from a quality perspective, how we perform from a cost perspective. There's a reason to think about this as strategy. So let's look at some of the evidence. So this is an article from the Journal of American Board of Family Medicine by Bertakis and colleagues. And what Bertakis and colleagues said, well, what they ask is patient-centeredness related to overall utilization? And so they evaluated two groups of patients, one with a more patient-centered approach, the other with a less patient-centered approach, 50% less utilization of healthcare resources by those with a more patient-centered approach. This validated earlier work from Epstein and colleagues in the Annals of Family Medicine that found the same thing over 3 years. A less patient-centered approach was associated with higher cost. This next study by Glickman in Circulation looks at and answers the question, I think, for a lot of folks in healthcare about what do these HCAHPS surveys really tell us? Are they valuable in any way? So remember, Medicare is paying us based on it. So this study by Glickman, he actually looked at how patient satisfaction, according to HCAHPS, is correlated with mortality and outcomes for heart patients. And he found that higher satisfaction was correlated with better outcomes, even when you controlled for adherence to clinical guidelines. So, and the interesting thing that Glickman points out, and I want to read you this quote, because I think this is important, and I hear this comment a lot about why we can't do better on our patient satisfaction scores. He says, patients seem to differentiate between technical and non-technical aspects of medical care. And in their study, he says, increasing the patient overall satisfaction score is less about making the patient happy, e.g. improving the food, the room decor, etc., and more about increasing the quality of care and the interactions between patients and staff, and particularly between nurses and physicians and patients. So patients know good quality when they see it. They may not understand anatomy and physiology, they may not understand the technical aspects, but they know it when they see it, when it's good quality and when it's bad quality. This article from the American Journal of Managed Care is from Boulding and colleagues, and they studied the relationship between patient satisfaction and 30-day readmission rates. Improved patient satisfaction overall and improved patient satisfaction with the discharge process resulted in lower 30-day readmission rates. So that's what they demonstrated. And in this Health Affairs article, Hibbard and colleagues found, again, patient activation. So how well is the patient engaged and activated in managing their own care? So the higher patient activation score, the lower the cost by about 21%. And then this next study, I'm going to quote cite the third author because you may recognize the name, McGrew and colleagues, and Flood, first author, that we studied the effects of the ACE model of care on two like units. So these units were controlled for payer mix, they were controlled for age, they were controlled for gender, they were controlled for case mix. They had the same doctors on both units treating, just one in the ACE model of care, which is patient-centered, and one on the standard model of care. Same doctors. We found lower length of stay, lower variable costs, so not just lower length of stay, lower cost because of we cut a day off, lower variable cost, and lower 30-day readmission rates. So clearly there's something to this. There is evidence that shows that this can be an effective strategy. When we engage with our patients and have them help us design our systems, you can see a positive impact, and you can see the relationship with respect to organizational strategy. So what's the return on investment? And I think it's clear, and I think we've talked about some of this already. So improved performance on value-based purchasing, lower 30-day readmission rates, lower cost of care. And I haven't hit on this much, but Plaintree has demonstrated over and over again, when they implement patient and family-centered care on units, staff and faculty satisfaction go up. Because you're focused on what you got into this business for, what you devoted your life and your career to. You're connecting back to that meaning and that purpose for your work. And our patients are happier, which makes the day go better, right? And improved reputation and market and to drive growth, which is important for our strategy, and improved health outcomes. So when we reflect back on our strategic plan and the road ahead, these are our pillars, and you look at the strategies that are outlined under each of these pillars. We've covered most of them. We've covered people, we've covered the impact on quality, we've covered the impact on the health system, strategic growth, financial success, the health of the community, and I just make two comments on research and education. So research, there is a whole line of funding out there around patient-centered, patient and family-centered care. The PCORA grants, which we've successfully have one of those here, maybe have more, but I know one of them. So this is an emerging field of research, and it's also critical for how we educate future doctors, nurses, and other healthcare professionals in how to be successful in a reformed healthcare environment. After we get done transforming everything according to all of this change we're going through, how do we train people to be successful in that new environment? So let's talk a little bit about what's happening at UTMB. Let's start with the Oliver Center, who's really been leading the way on campus with empathy training. Training our residents in how to develop improved empathic skills in their discussions with patients. There's a whole body of literature that says by doing that will improve adherence to the patient's treatment plan. And my guess is improve patient satisfaction. The Oliver Center is also working on some pilots in shared decision making and is audio recording appointments so providers can get direct feedback about their interactions with patients, what they said, what the patient said, what they heard, and reflect back on their own communication styles so they can improve. Additionally, we've been deploying patient advisors. So we have a patient advisor that sits with us on Operations Council. So some of you may not know what Operations Council is. It is our meeting of all the health system VPs and AVPs, as well as some of the folks from business and finance. So every time we meet, we have a patient advisor that sits with us. And it's been really, really great. Bonnie has enriched our discussion. I think it's kept us focused on the important stuff. And it's been quite a ride. It was a bit of an experiment, but I think it's been a good one. We've also deployed patient advisors in other areas. So as we're designing our new facilities, we've got patient advisors on a number of the task forces, so helping us pick our furniture. And let me just tell you, we are having the hardest time finding a couch that is comfy, right? And our patients and families, besides the advisor we have on the furniture group, we've expanded that out to a larger group of patients and families. We've had patients and families through our mock-up rooms giving us feedback. It was a patient that noticed, you don't have a hook in the bathroom. So if I go in to take a shower, where am I going to put this? Right? On the floor? Which, ew. You know, we all would think that, right? Ew, I'm not going to put my robe on the hospital floor. Ew. So, so there was no hook. Things like that are just obvious and that we might overlook because we're worried about where the gases are in the room and what kind of bed are we going to have and how will the bed alarm and so on. So they've been very much involved in that. And then we're undergoing a food service request for proposal, and we've got 2 patients sitting on that group helping us think about who should be providing our food and how should that happen and what would be helpful from the patient's point of view in terms of food service. In the ambulatory setting, there's a lot of work going on around patient-centered medical home. Family medicine has led the way in our certification as a patient-centered medical home. And this work is really about that activation. How do we activate patients to be engaged in managing their own health? And how do we better partner with them? So we're taking the work that has happened in family medicine and continuing to advance that work, but also spread that to our other primary care practices in internal medicine and in our CBC clinics. And then the Commit to Sit program. Dr. Ojo is here. Dr. Ojo and Dr. Sonstein and Dr. Underbrink and Dr. El Said, and did I forget anyone, Dr. Ojo? Good, okay. Brought us this program. So we know that when doctors sit down with their patients, they're delivering a couple of messages. 1, I have time to talk to you. 2, I'm interested in talking to you. And 3, I'm going to get down and sit at a level where we're eye to eye to offset some of the power dynamics that exist between patients and doctors. We also know that when you sit down, patients perceive that you were there longer, regardless of how long you stay. So Dr. Ojo and company brought us this program, which you've probably seen the posters, and we supplied chairs in the room because the doctor said, we'd like to sit down, and they went and trained some of the other faculty on this concept, but there's no place for us to sit in the room. So we've installed chairs in all the patient rooms. I think they're almost all in, and so that our physicians can sit down and have a conversation with their patients. So those are just a few things that are happening now, and I think there's a lot more to come as we think about how we integrate this concept as a strategy in our organization. This isn't, I said several times, this isn't new. It's been going, it's been Plain Tree since 1973, it's been around. So it's not new, and it's not new at UTMB either. When I first got here, I saw this quote, which was attributed to Dr. Richardson, and that this is what we wanted to do. That the care you will receive here at UTMB will be the same care as the most cherished of my loved ones would receive. That's a pretty powerful statement. And it is very reflective of what we've been talking about. So this is already a part of who we are. And I think if patients ran our hospital, they would take a look at this and say, you're on the right track. So thank you. Happy to take questions or talk or whatever you'd like to do with the last 20 minutes or so. Thank you. And I also want to thank the Oliver Center for providing lunch. So thank you very much.